Thank you. I want to thank Mary Lou and Dr. Lee for asking me to participate. As I told you, I've been here so long. I'm part of this scene here. So my topic is non-invasive treatment for facial dystonias. I need to go through some of this, but very briefly. And for those of you who are not familiar with how the brain is organized, this is the cerebral cortex, the light brown, and that's the thinking part. This is the vision part. This can you see that? No. Anyway, that's the thinking part. And below that, I can walk around. No. Below that is called as brainstem, different parts of the brain that are responsible for the centers for breathing, the heart, swallowing, speech, and all of them are grouped in there. And the different nuclei that are responsible for these functions are all integrated down there. So that is the most important part, the vegetative part, to keep you alive. And the top one is the thinking part, and that is cerebellum. And there's one more area called basal ganglia, which is hidden there. So the facial dystonias, or in fact dystonias, may have something to do with one of these parts or all of these parts. Now, non-invasive treatment for blepharospasm and hemifacial spasms. There are different kinds of treatments. Treatment directed against cortical mechanism. That is, something is wrong with this part of the brain, and that causes dystonias or hemifacial spasm or blepharospasm. And there are things that can go wrong with this part of the brain. It is the brainstem mechanism. And things can go wrong with the basal ganglia. These are different theories. And there is substantial evidence to support each of these theories, but they don't talk to each other. It's like a neurology department. We don't talk to the stroke guys, and we don't want to talk to the stroke guys. So same way, treatment directed against brainstem mechanism, treatment directed against basal ganglia mechanism, treatment against at the end organ, that is the muscle level. Okay. In order for me to explain this, I need to show this. This is the thinking part, the cortex, and there is what we call as homunculus. That is, your toe to top of the body, every inch, millimeter of your body is represented in that cortex. The movement part and the sensory part. Similarly, there is a visual organization, auditory organization, but we won't get into that. If you look at this carefully, there is the eyelid there, eyebrow there, and the muscle above the eyebrow is the frontalis muscle. And this is the nose, and this is a big protruding lip. The amount of cortical representation of lip is huge because of our capability to use the lip for communicating and speech. And below that is the tongue. The main function of the tongue is for speech and then swallowing. Okay? And then there is the pharynx and the larynx here. And some of the severe dystonias of Meigs syndrome, you even get platysma contraction. So this organization is important for you to remember. If you cannot remember, I'm going to give you a little clue to remember. This is Mick Jagger. He was born the same year as I am. I have special kindred feeling towards him. Not towards all his girlfriends and wives, just him. And look at him. He's got the eyebrow there. Nose. Look at his pouting lip. And the lip representation so huge. And the tongue sticking out. I bet you'll never forget this. So this is real. I mean, this kind of representation of the cortex is so real and well established. Way back in the 40s, scientists, neurosurgeons, and neurobiologists defined these areas in Montreal as well as in Johns Hopkins, and very well established organization. So what happens in hemifacial spasm or blepharospasm? What might be happening is there's a thunder and lightning strikes. And these neurons become suddenly electrically vulnerable. The excitability of these neurons, for some reason or other, get altered. They're all hyperexcitable, and they fire. Depending on the area involved, intensity of this electrical instability, you can just have the eyelid. There are two kinds of blepharospasm, according to me in my clinic. One where just the eyelid drops or blinks, frequent blinking. The other one is squinching of the eyes. The Botox treatment varies for these two. Okay? If you just drop in your eyelid, you just inject in the eyelid, but if you're squinching, you need to inject even the frontalis muscle. Or if the electrical instability is higher or more severe, you get lip movement or contraction, and the tongue sticking out on occasion, and the entire face goes into spasm, along with platysma or spasmodic dysphonia. You can have a combination of all of these, and that is the worst kind, called Meigs syndrome. Usually induced by medication, but that is a collective severe form of facial dystonia. So what are all the drugs, non-invasive treatment approach for this? The first thing is that, okay, these brain cells are all out of control. They're firing out of control. I'm going to turn the switch off. I'm going to calm their excitability down. The first thing that comes out is, oh, I'm going to give you anti-seizure medicine. Why? Because we know very well from Dreyfus's work in 1940s and early 50s that if we give seizure medicine, the excitability of all these neurons come down. So you usually go to a regular neurologist, not a movement disorder. He'll start you with the Dilantin, depending on how old he is. Then you go to Tegretol, then you go to Dopamax. Oh, I'm sorry, Topamax. And then you keep on going one by one, depending on the seniority of how long you've been in practice. Okay? So none of them work, literally. These drugs, the main idea behind this drug, how it works is to suppress the excitability of the brain. Even though you specifically want this area that is hyperexcitable to be suppressed, these drugs suppress the entire brain. So you become a zombie. And that may give you some kind of relief because you don't give a damn. So that is the one way this works. Okay? And you're all happy. But the only thing is, after a couple of months, you're tired of this crap, tired of being drowsy, and said, do something else. Okay? So most of this is less effective or not effective at all. And it makes you dopey, grumpy, groggy, whatever. So some of the other guys came up with this idea, okay, this is not working. I'm going to use brute force. I'm going to beat the hell out of you and take charge of the situation. And they came up with an idea called transcranial magnetic stimulation. Oops, where is it? Oops. Okay, I think I lost I was dopey and I lost that slide. So what it is a magnet. You put a single coil magnet and activate it, and it generates a magnetic field, and it's supposed to go through the scalp, on the skull. It's non-invasive. It's going to be put on right on your top of, less hair works better. I see quite a number of candidates here. So it goes through and it interferes with the magnetic field of these brain circuits and kind of suppresses it. Or there are two coils. One is not good enough, two. Sometimes they put two. So one coil generates one field, another coil generates another field. Somehow they work together and neutralize. Well, unfortunately, they don't work. Mark Hallett, that whose name was mentioned, he's a pioneer in this field. The Japanese guys are really gung-ho on this, and they do an excellent job of honing down and trying to work. If not for dystonia, they work reasonably well for cerebellar disease. So, but they are not really effective. So, there are con artists in every town. People will entice you to get into it. Don't do it. Okay? Take a hammer, hit on your head, and see whether it works. That's better. Okay? Yeah, some people get headaches, and you're trying to actually get rid of the facial twitches. Sometimes it causes facial twitches. Keep that in mind. Okay? Lightheadedness, serious but uncommon side effects are seizures, mania. I don't want that, especially in bipolar patients. Okay, now let's go to brainstem mechanism. Same thing. There are reticular formation. There's an area called reticular formation. It sends its tentacles to different parts of the nuclei, different parts of facial nucleus, motor nucleus of the fifth nerve, and all of these are integrated, and suddenly they fire, and you get spasms of this. Once again, the approach is same thing. Anti-epileptic drugs, they don't work. But drugs that are directed against some neurotransmitters, these are neurotransmitters whose cell bodies are located in the brainstem area. From there, they send their branches. So a couple of guys came up with the idea, why don't we mess with these neurotransmitters? Bring their level down or bring their level up and see what happens. It's an old idea. For example, this is a paper in 1990 or something like that. There is an old drug called periactin. You can't even get that anymore. It's only a generic drug. It blocks the serotonin histamine neurotransmitters. Didn't work. Even though it was 2 or 3 papers, doesn't work. And some guys thought, I don't know how they came up with this idea. Let me give Ritalin, improve the norepinephrine levels. That may help. Obviously, I'm worried about it. We don't want to get you into a speed addict. Okay, so drop it right away. Okay, and a couple of other drugs that came about is calcium channel blockers. They don't work. Okay, they not only don't work, they slow your heart, you drop your blood pressure, and a few other things are not working right. I don't want to mention that. Okay, so treatment directed against the basal ganglia mechanism. In 1960, the first drug for Parkinson's was discovered, actually in 1957. Okay, the idea that dopamine is a neurotransmitter came about in 1956. And we started using dopaminomimetic, or drugs that improve dopaminergic transmission. When we gave too much, suddenly we realized it causes more movement. So too little dopamine, like Parkinson, you don't move. Too much dopamine, you move too much. You think too much and you move too much. So people started having facial spasm, severe generalized dyskinesia, dystonia, and suddenly the concept came about saying, hey, the dopamine system has a major role in this. And where is maximum amount of dopamine? It's in the basal ganglia. 80% of all dopamine in the brain is in the striatum. So suddenly the dopaminergic hypothesis of dystonia has come about. And it has really advanced this field incredibly. And we are recognizing these dystonias much more easily now. And most of it is by the movement disorder people. So what do we do now? Okay, too much dopamine causes all kinds of spasms. Let's block it. Simple thinking. So most anti-dopaminergic effects decrease the intensity of normal facial dystonia. If I give you a dose large enough to block your dopaminergic input or transmission, your dystonia will get better for a short time. But in the long run, it may actually cause a tardive dyskinesia, which is even more worse form of dystonia, especially jaw opening, jaw closing dystonia, Meigs syndrome. These are all impossible to get rid of. So I highly recommend, I know many of you have tried it different times, do not take any of these drugs, unless you have severe. Sometimes the dyskinesia can involve the chest muscles. Incoordinate movement of the right and the left chest muscle can cause acute respiratory crisis. So at that time, we had to give this drug to calm you down and then pull you out of it later. Okay? So for an acute, brief challenge or severe dystonia, we might give you this, but we don't like to give these drugs in the long run. So if you go to your doctor and anybody wants to give you this, back off. Okay? And this is one of the oldest drugs that we have ever given for dystonias. In generalized dystonia, the Columbia Movement Disorder Group used to use so much, 80 milligram of Artane. And people didn't know where the hell they were. Forget about their dystonia. Okay? So it causes lapses in memory, confusion, cognitive dysfunction, and all of that. We stopped using this. With the advent of Botox, a lot of these drugs have been completely eliminated. Now comes the interesting part. Cannabinoids are pot, marijuana. And maximum intensity, interestingly, the basal ganglia has the highest intensity of cannabinoid receptors, or receptors for pot. That means the brain naturally has a place to accept pot. Okay? So we don't know what it does. I'm not recommending you to buy this, and if you do buy this, give me some of it. The minute I give up my license, I'm going to use it. Okay, so I've been waiting for something. I've been a clean guy all my life. I'm tired of it. So this paper came in early 1990. Not recommended because we do not have an organized clinical trial. Okay, so it's definitely not recommended. And you don't want to get into trouble in Louisiana. Our governor is a tough cookie. He knows about him. Treatment directed against end organ or muscle mechanism. The most important, this is the neuromuscular junction. When all these brain areas fire too much, electrical impulses come through this nerve, and then they talk to the muscles here. So the botulinum toxins work here. I'm not going to talk about this, but they work here. One of the key minerals that is responsible for proper functioning of botulinum toxin is zinc. So some wise guy who probably works for the food industry said, oh, okay, I'm going to make this new drug called zinc phytase supplementation. He wrote a paper in 2012 and said, if you give this, it makes the Botox work longer. Within about 12 months, this guy came and knocked it down. So the point of me showing this slide is, don't believe everything you read in internet. We need to test it scientifically and convince ourselves before we can convince you to use it. And we're not convinced ourselves about most of these things. So my final recommendation as a senior neurologist here, in general, non-invasive treatments for dystonias don't work. Don't waste your money. Go and buy that stuff. No. Find a good movement disorder physician. I'm not trying to be biased here. Bright neurologists can do what we do too. But we have more experience. We see more of you patients. We've seen varieties of expression of these disorders. And we've seen varieties of responses from individual patients. So we have more experience than the regular neurologists. neurologist. So find a good movement disorder physician and work with him or her. Okay? Thank you.